double-stranded DNA. I am sure that if you have not sent in your answers, then this is one of the answers there. More than 200 genotypes, 49 species. 30 to 40% of them, especially that belonging to the alpha genus, tends to infect the human genital tract. The natural history of these cancers are that around 80% of the women would actually acquire the infection during the part of their lifetime. However, close to 90% of them will actually clear the virus because of their innate immunity. The problem is 10% of the patients. Now we stratify the HPV infections into a low risk HPV, which includes the HPV 6 and 11, and this causes mainly genital warts, anogenital warts, and other warts in the body. Mucocutaneous manifestations of HPV are because of the low risk HPV, HPV 6 and 11. You really have a lot of high risk HPV as well, right from 16, 18 to 59. 16 and 18 are implicated in the carcinogenesis of squamous cell carcinomas of the cervix, whereas 18 and 45 have been implicated in the adenocarcinomas of the cervix. Apart from the cervical cancers, you've got 6 different types of cancers as well, and here are they. Close to 100% of the association of HPV is with cervical cancers, and there you do have a lot of evidence to screening in cervical cancers, and I'm going to talk about that in a little while. 50% of penile cancers and a host of the women cancers, the vaginal and vulval cancers, and 88% of the anal cancers are attributable to HPV cancers. 35% of the all oropharyngeal cancers across the globe, but if you see there are differences. In the US, for example, about 80% of the oropharyngeal cancers are attributable to HPV, whereas in India, the percentage seems to be around 20%. So all in all, you have about 35% of oropharyngeal cancers, but the maximum attributable cause of HPV to any cancer is close to 100%, and that's of cervical cancers. By and large, 4 to 8% of all cancers are caused by the HPV infection. Now, there is something called as a vulnerable population, especially the immunocompromised patients, the HIV patients, and the risk factors that contribute to HIV. Transplant patients and autoimmune patients, they are slightly under a higher risk of contacting the HPV infection. Now, coming to cervical cancers, little bit of the epidemiology as we breeze into the evidences pertaining to the screening and vaccination. The 4th most common diagnosed cancer globally, the 4th most common cause of death among women, about 5,70,000 all cases and about 3,11,000 deaths. In India, you see that it is one of the 2nd largest cause of cancers. It's been overtaken by breast cancer as the #1 cause in women. Close to a 1/5 of the worldwide burden of cervical cancers actually is in India. 85% of the burden of cervical cancers is in the low and the middle income countries. In India, we would see just under 1 lakh new cases and just over 60,000 deaths. And this was the data based on the Globocan 2018. Lifetime risk is 1 in 53. The age incidence is 22.9 per 100,000. Of course, it varies across many registries. So now what we know is that it's definitely a global health problem, despite the potential for prevention through organized screening programs that are happening. And more recently, I think we have a lot of HPV vaccination strategies that are really good to talk to. The trends, the global trends are actually slightly different in the sense, in developed countries, what we observe is that there is a marked decline in the incidence of the cervical cancers. Whereas in the low and middle income countries, what is happening is that the trends are actually slightly different. In the sense you have a slightly higher incidence. I have a little problem with moving my slides. I don't know why it's getting stuck.
It's not moving your slides, sir.
Yeah, I think it's getting stuck.
So what you can do is you can stop screen share and re-share it again. It will.
Yeah, I think now it's going. There is some problem, and this waiting room is also coming in. And sort of, so maybe you remove me as the co-host, and so
no, but then you will not be able to
Okay. That should be fine. Okay.
I'll handle the
First,
meeting room
yeah,
first.
great. Because it's just bang coming in between the screen share. Like, the problem with the low and middle income countries is that we don't really have a universal screening program. There is also, whenever there is a screening program, it's a little unorganized to a great extent, low coverage of targeted screening population, and that's the biggest bugbear of this. We do have a lot of opportunistic screening programs conducted by very many communities, NGOs, hospitals, etc. But there is no evidence to say that conduction of these opportunistic screening programs has a dent on the morbidity or mortality of cervical cancers. So definitely, we understand now that it is a global problem. There are health disparities. In developed nations, the burden is coming down, whereas in developing patients, it's increasing. So we now know that there is a definite need for cervical cancer screening. And these are the benchmarks for screening. So anybody who's interested should actually read this paper by Wilson and Junger way back in 1968, who has described the 10 tenets of screening. The 10 tenets of screening actually apply to the 4 cancers: cervical, breast, colorectal, and lung. And we will try to talk about cervical cancers now. Cervical cancers, in fact, is one of the ideal prototype of screening globally as well as in India, because it's an important public health problem. And more importantly, you have a long latent period that provides a very golden opportunity for us to intervene in the cervical cancer screening program. We know that cervical cancers, as we said, is 100%, almost close to 100% attributable to persistent HPV infection, and it has been labeled as a group 1 carcinogen by the IR. The appropriate screening strategies are 3. Visual inspection of acetic acid, that is the VIA combined with the villi strategy. The papillocytology test, also more commonly is called the pap smear, and the human papillomavirus testing. The VIA has been very popular in India. The advantage of doing the visual inspection of acetic acid is that it can be done by primary healthcare workers and doesn't really require a great laboratory infrastructure. Of course, it is readily done in the field. You obtain the testing result then and there, and you can do it as a screen and treat policy. And this is how we do it. It's recommended, it's highly recommended by the government of India as a screening strategy for cervical cancers. Women 30 to 65. VIA negative, you call the patient after 5 years. If they're positive by VIA, then you subsequently subject the patient to a colposcopy biopsy. And based on the results, CIN 1, 2, 3, you actually appropriately manage the patients. In fact, if you see for visual inspection for acetic acid, you have a couple of 4 randomized controlled trials, 2 of them actually from India. The largest trials by Shankar Narayanan in 2007 and by Dr. Shastri from the TMH group in 2014. And both these trials actually showed a 31 to 35% reduction in mortality because of cervical cancers over years. You do have very robust evidence to state that VIA is useful in decreasing the mortality of cervical cancers. But there are issues with VIA, and predominantly it is cost effectiveness and also issues pertaining to quality assurance. And hence, the recommendation to use VIA as a screening modality for cervical cancers is only for the low resource settings, and we actually practice it based on the recommendations given by the Ministry of Health and Family Welfare. In the high resource settings also, there is a role for VIA testing, and it is essentially used to triage the patients who are HPV positive, and this is something that I'll come into the later slides. Women who are found to be HPV positive plus VIA negative, they can actually be recommended for screening after 1 year. And if the woman is HPV positive and VIA positive, then you'll have to send the patient to a colposcopic examination. The next modality of screening is the pap smear. It was considered rather the gold standard for cervical cancer screening for more than a century, or more than a decade rather, 50 years. It was considered a gold standard. And high quality pap has actually tremendously reduced the incidence and mortality of cervical cancers by around 50 to 80%, and you have abundant data to tell this. But the issues of PAP is, again, it has a very low sensitivity. The meta-analysis by Krishnamurthy said around 53%, or rather it was a randomized controlled trial. There are issues of false negativity. And in the Athena study, it's a randomized controlled trial of around 47,000 women. We see that 1/3 of the patients of cervical cancers actually having a normal PAP result. So this is slightly startling. And the other issues with pap smear is that you do require a good laboratory infrastructure, microscope, resource personnel, and it's very difficult to find an expert cytopathologist who's able to sort of read the pap smears, especially in case of adenocarcinomas. There are issues in case of ascocytologies. There are issues. You really require a good cytopathologist to interpret the pap smear, and they are far and few to find, especially in a resource-constrained setting. The other issue with pap smear is that there are some recurring costs. For example, a woman who has undergone a pap smear when that's negative, she has to come back for screening after 2 or 3 years. And right now the cytology recommendation is to do it every 3 yearly. So again, the whole cycle will keep starting and keep continuing to the lifetime of the woman. The other issues with pap smear is that it has failed to actually significantly reduce the impact in low income countries. Mind you, I told that pap smear has reduced mortality by 50 to 80% in the high income countries. The reason is that they offer a very high quality cytology program. But the low and the middle income countries are unable to match up to the high quality cytology programs that are offered by the high income countries. And that is the reason why PAP, although it is a reasonably good test, has failed to make a dent in the mortality in the low and middle income countries. Also, in the high income countries, the impact of cytology based screening has more or less plateaued. So people felt that you require actually a more objective test, and there it comes the role of molecular prevention or the HPV screening. HPV testing, again, is a very objective test, both qualitatively and quantitatively. It can be reproduced very well, very high negative predictive values. And from the clinicians, the advantages are if you have a very high sensitivity to detect the pre-neoplastic lesions. The best test for reassurance of a negative, that is, if a patient is HPV negative, and especially if it's a high-risk HPV negative, rest reassured, you can tell the woman that you can come after 5 years and there should be absolutely no problem. Such is the validity or the high sensitivity of the test. And the interval right now is around 5 years, and we know that the protection levels extend beyond 5 years to close to around 10 years. There are numerous randomized controlled evidences that have come from comparing HPV as a testing compared to a cytology-based testing. And most of these tests show that HPV-based testing is 60 to 70% more effective than a cytology-based testing. And mind you, these are in the detection of CIN or pre-invasive lesions. How are the worldwide practices? High-risk HPV testing has become a primary mode of screening in various countries of the world. Australia, in fact, Australia was the first country which actually made HPV vaccination pretty mandatory, and they are seeing a drastic reduction in the rates of cervical cancers. Many other countries, close to 60 countries across the globe, has made high-risk HPV testing as a primary modality of testing for cervical cancers. In the United States as well, there is an evidence. Of course, there are about 4 bodies in the United States which come up with guidelines. A lot of bodies actually recommend co-testing approach, that is testing for HPV along with the cytology, but the newer evidences actually pertain to primary HPV testing alone. The primary HPV testing was also recommended by a lot of bodies like the European Union, the ASCO, the World Health Organizations, and the ECHO, and also as a recommendation-based testing in a resource-rich setting by the FOXC as well. That's the Indian body. So practically, if you see the screening recommendations, if you type the screening recommendations for cervical cancers, you'll get a lot of different data, primarily because they are all risk stratified or resource stratified. In a low resource setting, like in our setting, you have the primary approach, that is the visual inspection by acetic acid. Whereas in a good resource setting, they say that, up from 25 years to 65 years, you do some form of testing, but never do a HPV testing less than 30 years of age. So if you are to do a HPV primary testing, or if you are to do a HPV as a co-testing, you have to start at 30 years and do it every 5 years up to 65 years. And there is very little data to test beyond 65 years and less than 20 or 21 or 25 years. And that's the recommendations would actually vary. And this is the risk stratified approach. And most of the guidelines now are risk stratified based on the setting, the basic, the limited, and good resource setting. As I said, in good resource setting, right from 25 to 65 years, preferably to have a co-test or a primary HPV test. Whereas in a low resource setting, again, it's 30 to 65 years, and you can do a VIA-based approach that is starting at 30 years and repeating it every 5 years. And in India, as I said, we follow the VIA approach, and this is recommended by the Ministry of Health and Family Welfare, and it's one of the screening guidelines that say that every 5 years you do the test for women between 30 to 65 years. There is actually no formal recommendation by the government of HPV screening, but there are some guidelines, resource stratified guidelines prepared by the FOXI group that actually recommends for HPV testing in a good resource setting. Now, there are main issues of human papilloma virus in low income countries, and it's predominantly the costs of the testing. Also, the issue is that although it has a very high sensitivity of more than 96%, the specificity is slightly low. Pap smear has a better sensitivity than a HPV testing of around 96%. So the HPV testing, the main problem is the low specificity and the low positive predictive value. Again, we know that the natural history of HPV infection is that most of the women tend to clear the infections between 1 to 2 years. But the major bugbear in clinical practice is if you do a primary screening of a woman with HPV testing and you find a woman to be HPV positive, but you do not have a defined or a well-defined pre-cancer, then how do you go about it? And this is the major bugbear that major centers are facing across the world. It leads to unnecessary referrals. So the quality of your HPV program is actually dependent on how well you manage your HPV positive women. Whether you send all of them for colposcopy, then your systems are going to get overburdened. That means for every 1,000 tests, at least around 58 colposcopies you would need to do, and which is sort of untenable in any resource setting. So the reason is, or the way forward rather, is that you triage your HPV positive women in such a way so that you decrease the amount of referrals to colposcopy, and that is where the triage comes. So there is a little amount of complexity, but I'll try to simplify it for favor of everybody else. So how do you actually triage your HPV positive women? Supposing you do a HPV testing for a woman and she turns out to be HPV positive, how do you go about the management? And this is the major bugbear, and this is what we are discussing. You triage the woman either by using a VIA, that is a visual inspection of acetic acid in a low resource setting. And if the woman is VIA negative, then one approach is that you sort of, ask the patient to follow up after 1 year. If, however, the woman is VIA positive, then you send the woman for a colposcopy and biopsy. So that's one way of triaging the patients in a low resource setting based on the VIA positivity or negativity. And the VIA approach has been shown to reduce the colposcopic referrals from 7.6 to 1.5%. The other thing is that especially in low resource settings where the woman will find it very difficult to come to the clinic, there is something called as a screen and treat approach. Supposing you find the woman to be HPV positive, and in the field, if you're doing a visual inspection of acetic acid, and if you find it positive, one approach is to actually see and screen and treat the woman at the same sitting by any of the approaches like a whole knife, a cryo, or a thermal ablation. So there are certain criteria in which you should follow the screen and treat approach, but by and large, it is preferable, or rather, it is wise to send the woman for a colposcopy and try to sort of triage her risk, whether she belongs to a CIN 1, 2, or 3, and base your treatment based on that. The other thing that you can do to triage a HPV positive woman is to do what is called as a HPV genotyping. That is, you want to know whether the woman is HPV 16 or 18 positivity, and you can do a reflex pap testing, and I will exactly come to the rationale now. The rationale of genotyping, that is, knowing that the woman is HPV positive or negative can tell you something, but if you are able to do by genotyping, and this is what genotyping does. Genotyping actually tells you whether the woman is HPV 16 or 18 positive, or whether it is a non-16 or non-18 positive. And genotyping or partial genotyping is a methodology in which you can triage your woman. Supposing a woman is HPV 16 and 18 genotype positive, the woman should directly go for a colposcopy examination. If the woman is 16 or 18 negative, then of course there are slightly two other options. Either you can ask her to come after 1 year, or you can do what is called as a reflex pap testing for some of these patients. So risk stratification approach by partial genotyping will actually identify the high risk genotypes and the non-high-risk HPV genotypes and help in triaging your patients. So that's what I said. If your woman is HPV 16 or 18 positive by genotype, refer her for colposcopy. If she's other than 12 HPV, either you send her after 1 year for a repeat HPV testing, or do what is called as a reflex cytology. And in your pap smear, if you get anything more than an ascus, you again refer to this patient to a colposcopic examination. If the woman is HPV positive and the cytology shows a very low-grade cytology, then you can actually follow these patients after 1 year. And this is the chart in which I've sort of, it may seem a little confusing, but it's pretty rational and logical. That is, you do the HPV testing for the woman. If the woman is HPV negative, bang, she comes to you after 5 years, nothing to be done in the interim period. You can confidently say that the woman is HPV negative. The chances of developing cervical cancers are very, very minuscule, if at all. If the woman is HPV positive, either of the three approaches, do a VIA. If it's positive, again, go for a colposcopy. Negative, again, you repeat it after 1 year. You do a reflex cytology for this woman. This is one of the approach in which anything more than an ascus, you again refer this woman to a colposcopic biopsy. Or the third approach is to do a partial genotyping approach. And this is the approach which many of the developed nations practice. So what they tend to do is either HPV testing positive, they do a genotyping, and based on the genotyping, if she's 16 and 18 positive, she goes directly for a colposcopy. So this is the rational and this is simple and elegant and a very natural way to sort of triage your HPV positive patients. And again, if it's a co-testing approach, if it's your woman is HPV negative and cytology negative, then nothing to be done. Go after 5 years. If both are positive, colposcopy. If HPV is positive, if cytology is again negative, then you can sort of ask the patient to come after 1 year and have her retested. So I think this, although the algorithm seems to be a little complicated, if you apply your mind, it is very easy for us to understand this algorithm. The other ramifications of these are, as I said, the way a nation manages the HPV positive woman greatly influences the cost effectiveness of the test that you're doing. So if a nation is doing a partial genotyping approach to triage their HPV positive women, then the approach of HPV as a primary modality of screening becomes more cost effective. Cost effectiveness can also be aided by actually using this self-sampling approach, and I'll come to this in a little time. Again, as I said, the management of HPV positive women, there are now numerous other biomarkers that have been studied, like the P16H, Ki67 dual staining, the E6, E7 mRNA, the mRNAs, the miRNA staining, and certain methylation markers. So essentially what happens is these tests tell how best to triage your HPV positive woman. Again, there are a lot of health economic models, and I think I've confused you enough. I hope I didn't confuse you much more, but which actually say that there is favoring a HPV genotyping. For example, there is a Dutch study which was published a couple of years back, which said that in the initial 5 years of implementation of the partial genotyping, the costs were a little high for the HPV. But subsequently, what happens is after 5 years, the costs of primary screening by HPV would actually come down. So it is very important. One must understand that, for a nation to implement HPV as a policy, they'll have to look into a lot of things, not just the effect of mortality and morbidity, which seems to be really favoring the HPV, but also they should look into the cost effectiveness. And that's where a lot of argument happens, especially with regards to nations that have low or middle income. Then there's another potential of what is called a self-sampling. And self-sampling is essentially that you give a woman the cytology brush. Whatever you do in the clinic, the woman does it herself. And this is picking up in a big way, at least. A lot of publications showing the feasibility of self-sampling of the women. And the reason why they do a self-sampling is to try to make it more cost-effective. And of course, initially there were a little concerns about the clinical yield of self-sampling, but a couple of meta-analysis, and this was published a couple of years back, they say that self-sampling is attractive. The sensitivity or yield rather of self-sampling was almost equivalent to that of a physician sample. So in effect, self-sampling can also effectively improve the participation for cervical cancer screening. So the people who are actually been involved in cervical screening know how difficult it is to recruit women or ask women in the field to sort of come forward for testing. And they are promoting, the world rather is promoting self-sampling as a means to sort of encourage more women to come under the ambit of cervical cancer screening. And with more and more mounting evidence, there is a good concordance between the self-sampling and the physician related sampling. I think self-sampling is something that is going to get a lot of, even in, it will be acceptable in low and resource settings. In fact, in India also there are a couple of publications of self-sampling being quite feasible. So this is not just for the high resource settings, but even in the low resource settings, you have the two advantages. You try to encourage more women participate in your cervical cancer screening strategies. You have good concordance, and you are able to ultimately have a good quality program done. Again, there are some cost-effective data, not just from high-income countries, but in low-income countries. There is the PART randomized control trial, which was specifically conducted in the low-income countries like India, Nicaragua, and Uganda. And it also said that HPV screening can be cost-effective. And there are a lot of resource-stratified guidelines, especially the ASCO published some of these guidelines about 3 or 4 years prior. It said that the HPV testing as a primary test will be suitable for all the settings. In the limited resource settings, they say that you can do it instead of doing every 5 years, they say you can relax it and do it every 10 years. Ideal recommendation is to do it every 5 years. In a basic resource setting, the ASCO risk stratified or the resource stratified guidelines say at least do it once in a lifetime of the woman, and it can be potentially life-saving. So that much about the cervical cancer screening, about the HPV screening and how to manage the HPV positive woman. The other mechanism of preventing cervical cancers, or any other cancer for that matter, or any other HPV positive cancer, is through the incorporation of HPV vaccines. And let's briefly go into the evidence that is pertaining to that. The HPV vaccines, they are called as cancer prevention vaccines, primarily used to reduce the incidence and mortality of cervical cancers. But one must know that these clinical trials have proven its efficacy only in the reduction of CIN. So the purist will actually tell that the evidence to decrease the mortality of cervical cancers is not proven. It's just by a mathematical model that we are arriving at the conclusion. But it is very, very illogical to sort of, wait and do a randomized control trial of vaccine versus no vaccine, the end point being the development of cervical cancers. This cervical intraepithelial neoplasia seems to be a very good surrogate marker, and hence majority of the randomized control trials, and there are numerous randomized control trials which have tried to address these questions, have kept the development of the CIN as an endpoint. So you have two vaccines, the bivalent vaccine, which is the evidence is from the Triage trials, the quadrivalent vaccines at the Gardasil, which has the future 1 and the future 2 randomized control trials, and the nanovalent vaccine that the Gardasil 9, it's licensed, but it is not yet available in India because it targets virus-like particles. Again, there are two things when it comes to a vaccine. One must know the efficacy of the vaccine, and one must know the safety of the vaccines. As I said, a lot of randomized control trials have shown that it prevents the incidence of cervical precancers, that is cervical intraepithelial neoplasias, as well as cancers of the vulva and the vagina. And one must note that the best efficacy would be there if it is administered to individuals prior to the onset of the first sexual activity. With regards to safety, again, there are humongous data. I'm just not going into a lot of the data. More than 270 million doses of the HPV vaccines have been administered globally. Excellent safety data. There have been some unconfirmed or unfounded concerns which have been there. And of course, we are not going to talk about the political ramifications of this. But then again, that has been one of the reasons why a randomized control trial in India had to actually stop. Again, the worldwide practices, as I said, vaccinations is there in more than 60 countries across the world. And again, it's very ironical that the populations where there is a highest incidence and mortality of the disease are not vaccinated. So I think what is happening is the high income countries where the incidence of cervical cancers is low, the vaccination tends to sort of be on a very high. But whereas in slightly lower income countries or middle income countries where the burden of cervical cancers is slightly high, paradoxically because of the costs. Of course, a lot of effort is being done to reduce the cost. There are certain organizations like Gavi that's come and trying to support governments to sort of come against the cost to sort of see that close to 70% of the population actually tends to get some form of vaccination. You have what is called as the WHO strategic framework for cervical cancers in the southeastern region, and this was there a couple of years back. They had come with these recommendations. What they said is that you will have to have a very good health promotion program. It's very important. Like if you're ever starting a program, it's very important to create that awareness among the women. And they say 9 to 13, and of course in India the recommendation is 14, and they also recommend to vaccinate males as well. And I'll come to the Indian evidence a little later. 3 doses. Of course, there is a lot of evidence to come to 2 doses, which I'll again come to in a little time. There is one of the highest bodies, the National Advisory Body, which has actually recommended that HPV vaccine should be introduced in the universal immunization program. Even I think the Indian Association of Pediatrics also has got a similar recommendation. The FOXI, that is the Indian body, they also have had a recommendation, and this is a recommendation. In fact, this was published yesterday. This guideline actually had come on print yesterday. They said that HPV vaccines should be licensed, is currently licensed in India for women aged from 9 to 45 years. Of course, the target population, as I said, is 9 to 14 years before the onset of the first sexual activity, and that is when the efficacy of the vaccine will be very high. So any girl who is less than 15 years, 2 doses at an interval of 6 months should do. Whereas if the woman is, the evidence is also more for women for girls rather between 15 to 18 years. For now, that the cutoff of 15 has been set. If the girl is more than 15 years, or if there is any immune compromised patient like HIV/AIDS, or any sexual assault survivors are there, then they said that you must do 3 doses again. For Cervarix, it is 0, 1, and 6, and for Gardasil, it is 0, 2, and at 6 months interval. So you have 3 doses for this special group of women, or girls rather, who are more than 15 up to 45 years, immune compromised, and also the girls or women who have the sexual assault survivors. Again, older women, again the same recommendation is there. The vaccine may theoretically be beneficial for the women, but there is a high chance that during the onset of sexual activity, they may have an infestation with one or many of the human papilloma viruses. So the efficacy of this may be slightly decreased, but if you see the immune tendencies of these women, they tend to sort of mount a good immunity. And as I briefly mentioned about the Indian randomized control trial that was closed, but very intelligently, the authors used it as a window of opportunity to study the women who had been vaccinated by only 1 dose of vaccine, and they found that the immune responses for even a single dose of vaccination seems to be pretty good. And that has actually resulted in a lot of currently ongoing randomized control trials of seeing whether 1 dose of the vaccination is good enough versus 2 versus 3 enough. Of course, this is a very important question to be addressed for the cost effectiveness perspective. As I said, like everybody can read this publication, the FOXI expert group, which has come into publication just yesterday. Again, pregnancy and lactation is very important. I think it's to see that it is actually the vaccine is not recommended in pregnancy, but however, if the woman tends to get pregnant during the course, then it is not a reason for anybody to terminate the pregnancy, and it is not contraindicated in lactation period as well. There are a lot of other advances. As I said, the vaccine is actually recommended for males as well. And right from 2009 in the US, it's been licensed for boys from 11 to 21 years, and catch up to 26 years. And the Gardasil, that is a quadrivalent vaccine, actually prevents against the anogenital warts. And as I said, 90% of them are caused by HPV 6 and 11. Also, it has an ability to protect against anal, penile, and the oropharyngeal cancers as well. In the Indian scenario, the vaccination has been traditionally reserved for girls and young women, and currently the vaccination is not licensed for males. So even now, the target or the priority of the government of the day, at least the bodies, have been to sort of vaccinate the girls and not the men. It's also very increasingly relevant that we should engage with the stakeholders. And as I said, that this is told many a times by a lot of organizations, that the focus of cervical cancers has to be both the males and the females. If you are going to make a dent in the acceptability of the population or the community at large, you must involve them. And a lot of studies have shown that school-based educational interventional programs about HPV vaccinations are a very good medium in which you can educate the girls and the boys about the impact of HPV vaccination and cervical cancers, and also other HPV related cancers. And a lot of Indian data has been published which says that the knowledge and attitude that is there in the Indian community per se is very less. Maybe around 15 or to max around 40% seem to be remotely aware of anything like this. So a lot has to be done in terms of educating the public, also educating the stakeholders, that is the young girls and the boys, because they should not be pulled to some clinics and randomly put a shot of vaccination. They also have to be told exactly what needs to be done so that they understand the implication and willingly subject themselves to vaccination. And only then the strategy of vaccination is going to be successful. Again, from the futuristic perspective, you have a couple of things. You have the bivalent Chinese vaccine. I know China has a bad name right now, but there is a vaccine that's coming up there. India also, incidentally, is coming up with a quadrivalent vaccine. It has undergone successfully the phase 2 trials, embarking on a phase 3 trial, and hopefully in a couple of years, I think the vaccine should be ready for public use. And as I said, like a single dose vaccine studies are actually going on, not just India and elsewhere as well. So again, what is very important is from the vaccination strategy is that a lot of these vaccines actually cover only, say, around 2, 4, or 9 strains of HPV genotyping. And it's not. We know that HPV 16 and 18 constitute about 70% of all the cervical cancers. If you include all the other HPV types, maybe a 10% extra, but there will be 10% of the women who actually, despite vaccination, would still be under a slight risk of developing the cervical cancers. And that is the reason why, even though the women are vaccinated with HPV vaccination, they still have to undergo the mandatory screening protocols as laid out by the government of the day. So it is very important to understand that HPV vaccination is not foolproof. 10% of the women still have the theoretical possibility of developing cervical cancers, but of course the possibilities seem to be less because generally you tend to cover majority of the high risk types. And again, to screen the women who have been HPV vaccinated, the best strategy is to do HPV screening, because if we tend to sort of use a pap smear approach to a woman who has already been exposed to a HPV vaccine, then the sensitivity of the pap will be even very, very, very less. So especially in women who have had, or girls who have had the HPV vaccination, what they say is the screening strategy has to be by primary HPV screening, and it is effective and cost effective as well. So as I say that for any comprehensive cervical cancer screening program, you must have 2 things. One is you must have a HPV based, preferably a screening program that is HPV based. And WHO has put a note or a guideline recommendation saying that every country should aim that at least 70% of the women should have a high quality HPV testing. Again, there are issues of how the HPV tests are being done in the labs. There are 2, 3 other methodology. There is the point of care device, but the standard recommendation that has been approved by the US FDA is to use the COBAS platform, COBAS 4800 platform. That is the only recommended platform that has been approved by the US FDA. Of course, we in the Cancer Institute were one of the first to get the COBAS 4800 platform, and of course now I guess many other places around the country have got this facility. So it's not only important to sort of do the HPV testing, but it is very important for you to sort of, give it in a good lab that has got a good quality assurance. And believe me, some of these testings are so automated and the results are very, very easy and very, very effective and very, very reliable. So it is imperative that you do the HPV testing, but you do it in a good lab that has got a validated platform to give you the HPV positive result. Only then your screening program will be successful. And again, as I said, the evidences for vaccination is something that I've told. So the HPV testing per se is effective as well as cost effective, and that's the evidence that I've shown you. And as I said, with self-sampling and genotyping, there is a greater potential to reduce the cost of the HPV. And effective vaccination for HPV can not just reduce the burden of cervical cancers, and mark you, the incidence of cervical cancers is decreasing world over, and they believe that Australia may be one of the first countries in which the incidence of cervical cancers is decreasing, and it's very, very less. I think they actually plan by say 2035 or somewhere in which they almost should practically eliminate the incidence of cervical cancers by mounting an effective program of HPV testing and also by HPV vaccination. And again, as I said, the fallout will be there in other cancers as well, the other HPV cancers like the anal cancers, the vulvar cancers, the vaginal cancers, the penile cancers, and more importantly, the oropharyngeal cancers that seems to be an increase in especially in the West. Of course, whatever or a lot of whatever I've told has been captured in one of the articles that I'd written. Basically, it was written last year. It's available in the internet. Of course, it's not formally published. I've shared it with Dr. Geeta. So anybody who is interested, of course, you can search the internet and you can find it. Or in case you've got any difficulty, either you contact Dr. Geeta and I'd be very happy to share the full print of this publication. And I thank you again once again for this opportunity, and I think I'll be open to take questions on this topic. Thank you again, Geeta and Shubham.
Thank you, Dr. Arvind, for this excellent talk, which is extremely thorough and updated with all the latest evidence. Thank you so much. We'll take a couple of questions now. So the first question comes is there any particular reason for low specificity of HPV testing in low-income countries?
Where are the chat box? I'm not able to. Yeah, okay. Just open that up.
So there's a lot of chat in the box. So she'll just read out what is the important.
What is okay?
Yeah,
okay,
yeah. So don't go to the chat box, huh?
Okay.
I'll repeat the question for you.
Yeah, sure.
So basically, is there any particular reason for low specificity of HPV testing in low-income countries?
No, the HPV testing protocol, as I said, is pretty standardized. The testing will not vary from one country to any other country. It all depends on the standard methodology. As I said, the US FDA has currently recommend only one methodology by COBAS. Of course, there are 4 to 5 other platforms are there. So it is as good as you perform the test. If you use a standardized platform for HPV testing, then you're going to get the results which are there. So as I said, the sensitivity is very, very high. The specificity is slightly lower than compared to a pap smear. And the reason, as I told you, is that HPV screening for a woman by HPV also tests two things: the transient infections and the persistent infections. The transient infections are the ones that the woman is going to clear during her lifetime. We are interested in only the persistent infections. So that is the problem. So if you are testing a woman for HPV positivity and you find the woman to be HPV positive, you don't really know whether it's a transient infection that the woman is going to clear, or whether it is a persistent infection that can progress to any cervical cancer or CIN3. And that's where the problem is. And so that's the reason why the specificity seems to be slightly less.
Also, if you could add, if there are any molecular criteria through which we can know which ones are going to persist, if there is a stratification which is possible.
As I said, like there are a lot of molecular markers like the P16, Ki67, miRNAs, then the mRNA for E6, E7, and a lot of other biomarkers that they have studied, but none of them have actually been validated. So in the clinical practice, what we tend to do is one option, of course, as I said, is to refer all the HPV women to a colposcopy, which again is going to overburden your system. So you'll have to have a mechanism to triage your HPV positive woman, and you can triage it based on the setting you are. And I understand there is no universal answer to this. If you are working in a low resource setting, you can triage by VIA. If you're working in a high resource setting, you can triage them by doing what is called as the HPV genotyping. That is knowing whether the woman is 16 or 18 and accordingly sort of triaging the patients.
Fair enough. Continuing with the same, can you please explain the procedure via and villi? The students want to know because it might be important for their practicals. Just in brief, each procedure via and villi.
Well, they are all pretty standardized approaches, and there is a methodology. You use acetic acid, basically vinegar. And if you read the Dr. Shastri, when he presented this paper in the ASCO as a podium presentation and subsequently it came out as a publication, it said that the use of vinegar can reduce the incidence of cervical cancers by about 30%. And that was the title that was given there. So essentially it's an application of acetic acid, and it can be done by any, there is a protocol, and I'm sure that all of you can read the protocol. You clean it and then apply the acetic acid and see for an astrocyte reaction. If there is an astrocyte, and then it's positive. If it's not, then it is sort of negative, and that's how you triage your women, either in the primary setting or you triage your women who are HPV positive based on this approach.
Yeah. So another question that is there is if there is any data regarding the genotypic expression of HPV in the Indian population.
Yeah, there are a lot of publications that have come. There is a publication, I think, from the TMH that had come a couple of years back. What they said was that a lot of the infections among the women tend to be multiple infections, multiple HPV infections. About 30% were single HPV infections. About 60% of them were HPV infections that were caused by many other infections. Again, if you see, it all depends on because the problem about India is that, you don't really have a universal screening program of HPV across. So you have very many centers across the country who actually have adopted certain places or certain where they do their work, and basically it's data that has come from there. And generally, in one of the studies which was done at the institute, I believe the incidence was around 6%. And then there was another study from the earlier done which said the persistent infections were around 12% or so. So I think there is a little varying Indian data, but at least definitely there is data to suggest that a lot of the women from the Indian population tend to have poly HPV infections, that is HPV from multiple HPV rather than a single HPV. And again, I think for the postgraduates, the 16 and 18 genotype is more related to the more common squamous cell carcinomas. 18 and 45 is more related with adenocarcinomas. And the pap smear is actually very, very difficult to detect the adenocarcinomas. So adenocarcinomas are a little bugbear, and so you'll have to have a slightly different definition to challenge to go about with adenocarcinomas, and that is where your HPV can score over your pap smear in detection and management of these adenocarcinomas.
So the next question that is there is the role of HPV vaccination for oropharyngeal cancers. What is the current status?
It has been extrapolated. There are two things that are there. I know that Shubham wanted me to talk about oropharyngeal cancers. I think because it's a mixed audience, I would sort of give a couple of 2-3 take-home points about HPV positive oropharyngeal cancers. One is that the association of HPV with oropharyngeal cancers is slightly lesser than what is there in cervical cancers. As I said, in cervical cancers, the association is between 99 to 100%. Whereas in oropharyngeal cancers, the incidence per se is around 35% at max, 80% in US, and maybe 20% from what the Indian data sort of suggests. More than the association, the HPV in oropharynx actually is prognostic. So it tells us whether the patient will do well with treatment or not. So unfortunately, what has happened is they have tried to de-escalate the treatments in HPV positive oropharyngeal cancers in more than one way, but unfortunately, three randomized control actually failed to show that it could make any dent. So that is the reason why the therapeutic strategies of treating a HPV positive oropharyngeal cancer as of this date is no different from treating a HPV negative oropharyngeal. Again, coming to your larger issue of HPV vaccination, I think we have more robust data from the cervical cancers. It's extrapolated because, as I said, the targeting of males for HPV came about a little later. Initially, the target population was young girls and women. It was only from 2009 US started it, and even in India for now, you don't really have a vaccination protocol for the young boys or the men that has for the HPV that has got a link with the oropharyngeal carcinoma. So there is some indirect evidence to say that it can sort of benefit, and that is the reason why they say that it's not just girls, but you will have to target the boys also. Only then you will have a good 70% coverage, and the protection for HPV vaccination, as I said, is not just for cervical cancers, but it can extend to oropharyngeal and more importantly to other reproductive cancers as well, anal carcinomas as well, and vaginal and vulval cancers and penile cancers as well. So that's the larger sort of thing. You would sort of get more data from the advantage of HPV vaccination in men in the coming years.
Okay. The next question that is there is how does screening with HPV testing for help in women who are already vaccinated?
Yeah, as I said that uh, by using the bivalent strain, the Cervarix, you're covering only 2, 16 and 18. Gardasil, you're covering 4, 6, 11, 16 and 18. And in the pentavalent, which is not licensed in India, you're covering only 9. 16 and 18 constitutes around 70% of the cervical cancers, and a good 10% will be covered by the remaining. So definitely there will be a population of cervical or HPV that you're not covering by a traditional vaccination. And that is the reason why across the world, you should sort of have cervical cancer screening strategies for even women who are HPV positive. Again, there is a lot of futuristic predictions that with the successful incorporation of vaccination in the strategies, what is going to happen is the world is actually going to see they forecast by mathematical models, they forecast that a lot of the world is going to see a decrease in the incidence of the cervical cancers. Maybe the screening recommendations for these women may change over the years, but as of now, the screening recommendations for women who have been vaccinated vis-a-vis women who have not been vaccinated is pretty much the same.
Yeah, and also if you could add on to the self-collected HPV samples that are there, although they increase the participation, how effective are they in terms of their sensitivity and positive predictive value? The self-collected HPV samples.
As I said, the sensitivity is almost quite equivalent to a physician collected sample. Again, there are issues, and this is again for the trainees. The disadvantage of a pap smear is that sometimes you tend to get a lot of unsatisfactory smears. Sometimes they use what is called as a liquid-based cytology, and what is done is not improve the sensitivity, but a lot of the satisfactory smears has been little good. But with HPV, all you require is just a stroke, and you really require some little amount of DNA. And this DNA, and it's a very minuscule amount of DNA that you're going to require for this test. So it doesn't really matter. You should get the DNA, and that is the reason why in a self-sampling, if you do a HPV, there are a lot of studies, and I think as I showed you some 30-odd studies, meta-analysis of which have shown that the sensitivities and specificities of physician-collected versus self-sampling is pretty much equivalent. And the other thing is that, as I said, like a lot of countries, including the low-income countries, are adopting this approach for bettering their quality of cervical cancer screening.
Yeah, thank you. So also, can you mention about the role of booster doses for HPV vaccination?
Pardon? Yeah, okay.
Booster, yeah.
No, there is actually no as such booster dose that is actually recommended. As I said, girls who are less than 15 or boys also, 2 doses should be sufficient. And for more than 15 years, who are up to say 26 to 45 years, 3 doses at 6 monthly intervals should be there if you're going 2 doses. If you're giving 3 doses, then the dosage recommendation is either 0, 1, and 6 or 0, 0, 2, and 6, depending upon either the bivalent or the quadrivalent vaccine that you are. And the issue is that even for some reason, if the dose gets skipped for some reason or the other, anywhere between say around 18 months, if you are able to give the vaccination, you should be good. I'm not even looking at the chat box. I think so.
No worries, I'll
reading
read it out
there.
for you. So,
Okay,
the
Arvind, I
next,
wanted to ask you about this, vaccinating the boys.
Yeah.
Why, I mean, probably, we should have that as a recommendation in our country too, because I think what is happening in Australia is probably because both the boys and the girls are getting vaccinated.
Yeah, you're right, Geeta. The issue in the West is that oropharyngeal cancers are also becoming an increasing problem for them as well. In fact, when we spoke to the team at MSKCC, what they said was like 50% of whatever primary head neck cancers that they see in the clinic seem to be oropharyngeal cancers, and 80% of their oropharyngeal cancers seems to be linked to the HPV. So oropharyngeal cancers is a very huge problem, increasing by around 300% in the West. So that is the reason why there is a push for vaccination for the HPV positive for the boys or the men as well. Whereas in India, we are not seeing that much of an increase. By and large, the limited data that is emanating from India says that our HPV positive oropharyngeal rates will be in the range of 20%. But you're right, I think this is only pertaining to the oropharyngeal cancers. But there are a host of other cancers. Understandably, what happens is these cancers, the incidence are slightly lesser. Anal, vaginal, penile, and vulval cancers, the incidence is slightly so less that is the reason why the amount of data that we have from cervical cancers, you are not able to have in vaginal and vulval cancers because the incidence of these cancers are slightly. And you will have more data on oropharyngeal cancers again because the incidence in the West is going to be high. So theoretically, there is a point to vaccinate for all the 6 cancers. So the HPV vaccine, in effect, would sort of give benefit to all the 6 cancers. So agree with your larger point that even boys should be the target for HPV vaccination. Only then, if you are able to achieve that 70% coverage, you get what is called the herd immunity, and you'll be able to do good across the board for all cancers and not just only cervical.
But what has to go up is also the HPV testing. So the point is that for a lot of oropharyngeal cancers and a lot of anal cancers, we don't get very frequently HPV testing done. So if we have to prove that the incidence of HPV is high, we need to first increase the testing capabilities and the testing capacity in terms of cost and availability. Only then can we prove that these cancers are actually not related. And obviously, the tobacco overshadows our oropharyngeal cancer, so that is why probably we never focus on more. But we agree that males are the one that, and probably the program will also gain strength only when you are subscribing it to everybody rather than just the female population. I think that will also be a good impetus for the program.
Yeah, it is also important, right, Shubham? I think points very well made. But the larger issue of testing is that for a proven cancers, you only test for oropharynx because it's going to change your TNM. We have a TNM aid that has actually changed because of that. And that is the reason why we are changing. And the prognosis is better. Of course, we now know that treatments are not going to be better. But by testing a proven cervical cancer or a proven anal cancer, you're not going to do anything great by means of changing the treatment.
Yes.
So you test only the normal women for a screening for cervical cancers, whereas the approach in a HPV positive oropharyngeal cancer is you test the actual cancer patient, because the treatment implications and the prognostic implications are slightly different. So I think that is the distinction that I would like to make.
Great. So
Yeah. So we'll just take two more questions. Second last question being, so basically, is there still a role of the vaccine after exposure to HPV?
As I said, you still can give. So uh, again, I reiterate that the best effect of the vaccine would be before the onset of sexual activity, whereas the chances of HPV catching the HPV infection will be slightly less. But even so that is why the ideal target group, the population, the FOXI and the IAP have actually said that you'll have to keep it between 9 years and 14 years. But still they extended it by 26 to 45 years to extend the cover. So even though a woman may have been exposed to HPV, it is unlikely that she actually would sort of have exposed to all strains. So in effect, the vaccine can have some protect. What we know is that it is safe to vaccinate these women, and the protection, and these women also mount some immune reactions to the vaccine, so that's a good thing. And it is expected that some degree of protection would be there in these women as well. But agreed, the amount of protection for these women will be much lesser than the virus.
Okay, so Dr. Arvind, what I meant to ask by the ones who are exposed is the ones who are already having, suppose, an HPV infection, and you kind of treat them and they become HPV negative.
Right.
So is there a role of a therapeutic vaccine after that?
Yeah, it is. It is.
Yeah. So
As I said, like, you don't, because we don't sort of, you don't. That's why I said, irrespective of whether she has had an exposure or not, I think the recommendation is to sort of, give the vaccination as per some schedule, hoping that some degree of protection. We don't know what is the magnitude of protection, but at least definitely, as I hope that the pathogenic strains or the high risk strains are covered. So the thing is, if a woman is clearing the HPV virus, that means, like, she might have cleared a non-high risk HPV. So it is also very likely that the woman can catch a high risk HPV infection subsequently as well. So that is the reason why they sort of advocate vaccination for these women as well.
So, Dr. Shubham, can we take more questions? I think more and more questions are.
It's up to Dr. Arvind. There are just a couple of more questions, sir.
Sure, go ahead.
Please,
And
please,
as I said, Shubham, you told me not to look at the chat box. I'm just looking at the screen. That's it.
Yeah. Please. We are there to read the chat box for you, sir. Don't worry.
Okay. So, the role of vaccination in recurrent laryngeal papillomatosis.
Oh no, I think, as I said, the target is not has not been to sort of has not been tested effectively against the oropharyngeal subset. And one thing is right, is laryngeal papillomatosis is caused by the human papilloma virus, but we don't really have any robust evidence to sort of say that once you have sort of got laryngeal papillomatosis, by giving the vaccination, you're going to do any good for the patient. You just have to keep treating the patient. That's it.
Also, since the antibody titers tend to fall after 5 years, is there any particular time frame for which these vaccines are effective?
One must understand that we are only now beginning to sort of know the long-term data. The problem in the years or the earlier years is that we didn't have long-term data. Now only we are having some 10-year data. So what is effectively known is that these vaccines seem to be good for 10 years, for close to 10 years. That is what it sorts of the thing is there at this point of time. And now what is happening is we are entering an interesting phase wherein the women who are all, or the girls rather, who are all vaccinated, they are actually right now coming into the purview of the actual cervical cancer screening programs. So with years to come, there will be lot more of evidences. We know now for sure that the vaccine seems to be good enough for at least 10 years. So the data on the booster or the catch-up vaccines, we will get to know only subsequently. So till that time, I think the recommendation stands at 2 doses for young women and 3 doses for the select group of population, and a protection as good as 10 years. With more data, I think the recommendations may change.
Also, if post hysterectomy, there is a role of screening with villi or HPV.
Again, if the again there are, if you see very carefully the guidelines, I think a lot of these guidelines mention about hysterectomies as well. Like if the hysterectomy was per se done for a benign cause, then you need not sort of worry much about the cervical cancer screening for these women. But however, if the hysterectomy was done for a CIN, then there are some recommendations that you may sort of go ahead and do. So practically, I think there is a slightly conflicting evidence with regards to hysterectomy from various guidelines. But by and large, hysterectomy done for a benign disease, you can be pretty much reassured that the woman should be good.
So the last question to you, Dr. Arvind, what about immunocompromised individuals? How would you like to vaccinate them?
Yeah, definitely. I think I did mention this. The immunocompromised patients, be it HIV/AIDS patient, be it transplant patients, or be it any autoimmune disease patients, they are the group that are vulnerable. And there is a recommendation that you tend to give 3 doses of vaccination for these women or these patients to sort of circumvent that thing. But otherwise, the recommendations are absolutely no different.
Okay. Thank you so much, Dr. Arvind.
Thank you, sir. Thank you so much. I think I must emphasize that this is not the topic was not HPV vaccination. The topic was HPV, and whenever you get a question of HPV, obviously you have to end it on HPV vaccination. But before, can I ask Dr. Arvind to summarize what a model answer should have? What all. So we had a very nice presentation, but if we were to write a short note on HPV, what all would you expect in a model answer? What should be the headings and what should they emphasize on? Just briefly, around the 5 minutes.
Yeah, initially, I think you can sort of briefly describe what type of virus, say it's a double-stranded DNA virus, and how many genotypes are there. The other important aspect is that the mode of transmission it's a sexual transmission. 90% of the times, or 80% of the times, the infection is acquired by women, but 90% of the times it tends to clear off, and it is the persistent infection that is actually a problem. So you must say that the maximum association is there with the cancers. You'll have to list the 6 cancers. Also, what I didn't talk was there are a lot of benign manifestations of HPV virus also, because this talk was focused only on cancer. So that is something that I didn't cover much, but that is something that you all can cover in your short notes, saying the mucocutaneous manifestations of benign HPVs ranging from warts, papillomas, etc. You can write HPV, and you also have to write about low risk HPV 6 and 11, then the high risk HPV, especially 16 and 18, and the host of other HPV you'll have to write. And also, what I didn't cover here was also the methodology of HPV testing. And I think I deliberately didn't cover it because it's a little complicated. And essentially, you have a lot of point of care devices also available. You have certain standardized methodologies also available. So you can do it by various methodologies. You can do it by a standard methodology of PCR. You can do it by in situ hybridization. In case of oropharyngeal cancers, you can do it by in oropharyngeal cancers, at least, to say that there is a lot of concordance between P16 immunohistochemistry and the HPV positivity. But that much concordance is not there in many of the other cancers. Again, you must also tell what is the relevance of HPV. That is, prognostic relevance. And so you can divide, like, saying what is the role in when it comes to cervical cancers, then you talk about the strategies of screening and vaccination. When you talk about oropharyngeal cancers, you also talk about the epidemiology. You also tell the association of smoking. There is this criteria, the KK-ANGS paper that classified into good, intermediate, and low. Then you also tell the profile of the patients, the prognostic implications when you talk about oropharyngeal cancers. Of course, you can definitely mention about anal cancers, vaginal, vulval cancers, and sort of penile cancers as well. But I think the bulk of the thing is for cervical cancers, wherein you can talk about the methodologies of sort of very briefly just mention headings of VIA, pap smear, and the HPV. And also you can go ahead and tell what is partial genotyping, and you can also tell what is the about cost effectiveness of the entire approach is something that, and it's a very huge thing from a national perspective. Cost effectiveness is a very big thing. You can talk, and also you'll have to talk about self-sampling, because this is coming in a slightly bigger way. So by and large, this is how you tend to sort of, you can, and this is whatever I've told you possibly is, as I said, like the start of the program, it's more of an essay, because as I said, it's a slightly different topic, and I actually enjoyed giving the talk. I don't know how effective it was or how useful it was for all of them, but then I think it is, it just cuts across specialities, no? Because it's just right from head and neck oropharynx to the woman reproductive organs to the men reproductive organs. No, so it really cuts across all the specialties. So, and there are varying evidences. So, of course, I didn't really go into too deep evidences that are there for vaccination plus thing, but there are immense evidences that are there. It's very, very difficult for you, but in brief, in a nutshell, you can actually mention some of these evidences.
And that is why you were the ideal speaker for it, because you covered it actually thoroughly, right from the genotyping to vaccination. And actually what you also did was covered the cancer cervical screening actually with the 2 algorithms, and you actually beautifully explained it. So the detailing of VIA and the other stuff should be covered as a part of the cancer screening whenever we have that. But what is important is to focus on HPV, which was the topic for today. I'll just mention that we should also talk about the structure of the virus, probably a short code, the 2 type of proteins, the L protein and the E protein, E678 and the L12. Just a brief mention, draw a small diagram, because it it gives that you are thoroughly completing the answer and not just skipping over it. It's a very easy virus to draw. I mean, not much into it. So I think,
and probably also the latency of HPV, how the pathogenesis happens, how it goes on from completely something that is normal. You would usually, like you said, would wash out most of the time, and if you don't, if it doesn't and finds the ground to stay, then how it progresses from CIN1 to 2 to 3 and then to cancer. So, you have that diagram, we always remember diagram, which, comes up every now and then. But it was an excellent talk, Arvind. I think it's like you said, it's a very cosmopolitan kind of a topic, which I think has caught the eye of a lot of students. And I was just watching how many participants, lots of participants today also, but I think we hit an 88 at that time, at the peak time. And I think it was a great presentation. Thank you so much, Arvind. Thank you.
Thank you, sir.
Geeta,
thank you so much
for the opportunity.
Thank you so much. So, Dr. Geeta, you want to go with the quiz, the answers of the quiz?
Okay.
Yeah. So you can see my screen, and can you tell us the number of people who participated in the quiz?
So today we had about 12 participants. Last time we hit 28. So that was the largest number of participants. This time we had 12. But the thing is, this time, till date, we have had only one winner, meaning one person who's got all the answers right. But this time round, we have got about 5 people,
wow.
5 out of 12 who got all the answers right. So I think that's a brilliant thing. And I'm just working on this, probably in August, we should be able to come up with some sort of prize for getting the answers right. So one person, so if you've got 5.
A sponsor now.
Yeah. So I think we are in the process of doing that. I think by August, we should be able to have that in place. But if there are going to be 5, we will have a lucky dip. and
Yes,
get only
yes.
one. Okay, so the first question was papilloma viruses are characterized by what genetic feature? So genome of double-strand circular DNA encoding around 8 ORF. That is the answer. This is A or 1 as you would have written. And the second question, the answer to the second question, how does the papilloma family of viruses cause cancer? So it does that by replicating in dividing cells and encodes for 3 oncogenic proteins, which is E5, 6, and 7. Question number 3 is, which of the following HPV viruses are known to cause cervical cancer? So 14, 16, 18, 31, and 45. So all of these are oncogenic viruses because that is the answer to that question. Question 4 is, the successful anti-cancer HPV vaccine consists of, the answer is number 3, which is self-assemble of virus L1 protein into VLP. And question number 5 is, where in the body do oncogenic HPVs especially replicate? And the answer to this question is number 4, which is cervix and larynx. That was an easy one, I think. But in any case, let me just announce the people who had got the answers right. So that is the sequence we were looking at, 1, 1, 2, 3, 4. So Dr. Radharani Gupta, Dr. Bijan Kumar Saha, Dr. Alvina. So Dr. Radharani Gupta is from Kolkata. Dr. Bijan Kumar Saha, I think, is also from Kolkata, I'm not sure. And Alvina is from TMH. And Dr. Just a second. Okay, I don't know what. Dr. Prakriti, I think. Yeah. And Dr. Sharheen. So these are the people who got it right.
Wow.
And there were 4 others who got 1 wrong and got 4 right. So Kinjal Shah, Vani, Vasundhara, and Manish Jethani. All of them got 4 out of 5 right.
Perfect.
Looks like it was a relatively easier quiz because
Yes,
9 out of
yes.
12 people almost got there. So I think it is a brilliant session, not taking away anything from the students who answered the quiz right.
Okay, okay. I think we
Thank
had a
you.
wonderful session, and all thanks to Dr. Arvind. Thank you so much, sir. I think it was a wonderful presentation, and you cleared a lot of doubts for a lot of our students. And we really would want to have you again with probably a shorter topic, you know, a more concise one. But as your specialty is, you cut across specialties and can take any talk. So you are an asset to people like us. Thank you so much, sir. Thank you so much.
Thank you, Shivam. Thank you, Geeta. Thank you all.
Thank you. Thank you.
Okay, so we'll see you again next week. And the next week, the topic is metastatic renal cell carcinoma. What's the right approach? A very burning topic. We surgeons hate the topic because we want to do nephrectomies for everything, but you know, medical oncologists stand in a way. And so we have a medical oncologist taking it for us next time. I'll send you the link whenever it's ready. This video will be available on YouTube, on our YouTube channel. Thank you so much. Good night, everybody. Good night.